Let me introduce Dr. Groot. Dr. John Groot is a professor and chief of the Division of Neuro-Oncology, Department of Neurosurgery at UCSF. As a neuro-oncologist, he specializes in the diagnosis and management of patients with primary brain and spine tumors. Dr. Groot comes to UCSF from MD Anderson Cancer Center in Houston, Texas, where he served as Director of Clinical Research in Neuro-Oncology from 2013 to 2021, and as Interim Chair of the Department of Neuro-Oncology from 2015 to 2020. He joined the faculty at MD Anderson in 2004 after completing a neuro-oncology fellowship there. Dr. Groot completed his neurology residency at the Johns Hopkins University and received his medical degree from the University of Texas Medical Branch at Galveston. His undergraduate degree is from Stanford University. Dr. Groot is experienced in bringing new therapies from the laboratory into the clinic for treating patients with brain cancer. He has contributed to the clinical development of angiogenic molecularly targeted and immunotherapy treatments for glioblastoma, and he regularly advises and collaborates with other researchers on new and developing therapies. We are thrilled to have you, and thank you for your time, Dr. Groot. I'm going to pass it over to you and for your comments.
Great. Thank you very much. It's an honor to be here tonight with all of you. And thank you to Lacey, Mary, and Joni for inviting me. And thank you all for joining tonight. So hopefully everybody can hear me okay and can see.
Yes, we see your slides. Perfect. Okay. Thank you.
Great. So I was asked to present a little bit about some updates from the 2023 Society for Neuro-Oncology meeting, which, as Lacey mentioned, was in Vancouver, Canada this past year. And so I'll probably spend about the next 30 minutes or so kind of reviewing some of the highlights. So this is an outline of what I wanted to talk about. So I'm going to give you a broad overview and then talk to you a little bit about the different types of tumors that I'm going to present some updates for. I have to talk briefly about types of studies because it's relevant to sort of what we're discussing. And then I picked sort of 3 different areas where I thought there were some really very interesting results in glioblastoma, but also low-grade gliomas and also in meningioma. So when I was asked to give this talk, I wasn't sure the best way to approach this. This is our annual meeting, which is probably the largest collection of individuals who focus their careers and their life on studying brain tumors. And there's obviously lots of different brain tumors, both in adults and pediatrics. But it's grown and evolved over the years to become, a 4 or 5 day really intensive event. And it starts out with an education day where there's, some of the more senior investigators who are teaching some of the younger faculty or teaching fellows and residents about brain tumors. And then also in a focus on trying to take discoveries from the laboratory into the clinic. And then there's 3 days of really intense research presentations, and it's all the way from basic science to translational research to clinical trials and beyond. I just wanted to show this kind of opening. This is the web page for the meeting, and I just wanted to highlight the fact that Dr. Sean Hervey-Jumper was one of the meeting chairs and played a really critical role in kind of developing the program content. So again, going to sort of this issue of what are the updates and highlights. This is sort of showing the meeting by the numbers. So there were over 2,500 people that went from 45 different countries. And if you look at the number of presentations, there's 850 poster presentations. There were 250 oral abstracts. There's and then these rapid report presentations, which are really brief oral abstracts. There's just so much information that's being presented that I didn't feel like we could really kind of review everything. And so instead, what I did was sort of pick, one specific type of study to kind of present across multiple studies and multiple disease types. So it's going to feel like 26,000 registrants and several hundred presentations are all being narrowed down into like 3 or 4 different studies. But I felt like in a half hour that was going to be about what we could get in. So I'm sure everybody is well aware of the different types of brain tumors. And I just bring this up because I am going to talk about 3 different types of tumors. So as we know, glioblastoma is the most common malignant tumor. But if you look at all primary brain tumors, meningioma is actually more common, and a couple percentage of all people in the country have meningiomas. They're less common, commonly discovered because they're usually lower grade. They grow very slow, and many people die with them, not because of them. Yeah, but it's a very important disease that is studied very intensively here at UCSF. So I wanted to talk a little bit about that. And then there's been some really exciting developments in the world of IDH mutant tumors, which I'll show you in the next slide, but that would be the lower grade tumors such as oligodendrogliomas and low grade astrocytomas, both grade 2 and grade 3 astrocytomas. So we'll talk a little bit about that as well. So this is a slide that I borrowed from Dr. Taylor from her talk last year, which just shows the sort of the main classifications of the gliomas. So as has been well known for some time, glioblastoma, the most aggressive one, which again is around 20% of all primary brain tumors, is IDH wild type and has very characteristic pathologic features when you look at it under the microscope, as well as very specific genetic changes if you look at the genetic level. But this is in very sort of counter-distinction to IDH mutant tumors, which I'm going to talk a little bit about because we now have a new drug that is an IDH inhibitor. So I want to talk a little bit about that. But this predominantly looking at oligodendrogliomas, grade 2 or 3, and then astrocytomas, grade 2 or 3 is kind of where we're focusing with that particular therapeutic angle. And then here is meningioma. Again, for people who maybe not be familiar with this, meningioma are thought to come from the meninges, which is one of the layers along the surface of the brain. And it leads to very characteristic imaging changes, like you see here on this MRI scan, this coronal image, where you see a very, very brightly contrast-enhancing lesion, which is outside of the brain. It's not within the brain, it's outside the brain, but it can push on the brain. And then the more aggressive types of meningioma can actually invade into the brain and cause a lot of symptoms and problems along those lines. Okay, so switching gears, I just wanted to bring this up. I'm going to talk mostly about prospective studies. And when I say prospective, that really is just referring to the fact that there's a study that was designed that patients were going to get treated all the same way from the start and to the finish. And, the studies can come in multiple different varieties, but really prospective is looking forward into the future. So an intervention and then following the patient to see how they do. This is different than the retrospective study. I'm just going to present one retrospective study. I think that's the meningioma study. And that's really where scientists look at, in this case, actually thousands of patients that had been treated with meningioma in the past. And then they're going back and they're looking at what happened to those patients, looking at their tumor tissue and trying to understand, who did well, who didn't do well, who responded to radiation, who didn't respond to radiation, those kinds of things. So those are the two kind of types of studies that I wanted to kind of focus on tonight in our brief discussion. And then also stole this shamelessly from Dr. Taylor from her last year's talk. We're just talking about the phases of different clinical trials. I'm sure everybody is well aware, the phase 1 study is to look at the safety and to find the right drug dose. Then phase 2 is usually used to look and see whether a drug is effective or not, or at least there's a signal of efficacy. It might be in a smaller number of patients than you would see in a phase 3 trial, which is this is the definitive study. Those are usually randomized, they're blinded, they're placebo controlled, and they're really designed to definitively prove whether or not a treatment is effective or not. And so I'm going to talk actually mostly about the phase 1 and the 2, but there is actually one phase 3 for the IDH mutant tumors that I'll briefly talk about as well. So this is just as a reminder of the different types of treatments that we might provide. So obviously there's surgical interventions, radiation, and I bring that up because some of the work that we're going to look at has to do with the impact of radiation on outcomes. Then of course there's chemotherapies for patients, and then targeted drug therapy, which I'm going to talk a little bit about, and I'm going to go through some sort of schematics of what a targeted therapy is and how it might work in the context of cancer. So those are really sort of the main ones that we're looking at. So the first area that I'm going to talk about is glioblastoma. So there were 4 plenary sessions at the SNO meeting this year, 4 sessions over the course of 3 days. And so I'm going to really pick one presentation from each of those four plenaries. So the plenary is reserved for really the best work, the most outstanding, the most exciting, and so that's why I'm going to sort of delve into that for these 3 different diseases. So I just wanted to show what I think is a really exciting new therapy, and maybe some people have heard of this treatment before. It's been around for a couple of years, but it's a drug called BMX-001. And this is a drug that was being tested in a clinical trial. It has multiple mechanisms of action, but it's really thought to block the pro-survival signals within the tumor, and then to also enhance the pro-death signals within the tumor. So really to kind of attack the tumor on both fronts, to keep it from growing, and then also to make it die. And then it also has another added benefit, which is that it's thought to be neuroprotective. So when given with radiation, it's thought to sort of protect the normal brain cells from some of the toxicity related to the radiation, which I know is a really important consideration given the impact of radiation on normal brain and cognitive function. So when typically with a radiation treatment, what it's doing is the radiation is causing damage to the DNA. So the actual, genetic information within the tumor. And when it damages the DNA, that prevents the tumor cell from being able to divide. And so this drug enhances that action. So it makes it more likely to damage the DNA by increasing sort of free radicals and other mechanisms. And then, as I mentioned, for radiation, when it is attacking a normal cell, can cause other secondary inflammation, and that inflammation can cause, in the nervous system, damages to the normal myelin. It can cause cognitive function. Of course, we all know those things can decrease or diminish a patient's quality of life. So this drug is thought to really have those 2 main mechanisms of action, which is quite unique, because most of the drugs that we use are mostly just damaging tumor cells as opposed to protecting the normal cells. So this was a phase 2 trial. So this was actually a randomized trial, and it was randomized 1-to-1. So half the patients got the new drug and half did not. And in the phase 2, as you may remember, it's really looking to see whether or not there's like a signal of benefit to patients, usually looking at certain outcomes such as survival. This is the results of that study. And what it showed was that using this drug BMX-001, there was over a half of a year of improvement in survival for patients. So this, is obviously not a cure, but it's moving the needle in the right direction. And there's also some data around quality of life and cognitive function that I didn't present here, but showing some benefits in those areas as well, which is exactly the sort of the mix that we would want to have when we're treating patients with really toxic therapies like radiation. So obviously immunotherapy is a really, really exciting field. Immunotherapy has really transformed the treatment for many different tumor types. When we think about immunotherapy, I actually always think about Jimmy Carter and the incredible benefit that he had from melanoma and getting treated with these drugs called checkpoint inhibitors. So those drugs are now approved for a dozen or more different solid tumor types, and also some of the liquid tumors as well, like leukemias. So it's really a very, very effective therapy. And we've really struggled in brain tumors because to date, it really hasn't been shown to be as effective as it has been in some of these other tumor types. So there still remains, and I personally believe that immunotherapy is really the future for finding novel and better treatments for patients. But at this point, we're not quite ready to, wave our flag that we've actually made a really major impact in that area. That being said, there was a huge emphasis at the meeting around immunotherapy studies and even in the laboratory and also in the clinic. So this was one of those studies. This was a really important study that was run through one of what we call cooperative groups, which is basically a large number of institutions across the country that would all come together to run an agreed upon clinical trial. And in this case, this cooperative group is funded by the National Cancer Institute. So you can see there at the bottom, sort of the sponsors of this particular group. So this group was doing a randomized trial to look and see whether or not using 2 of the checkpoint inhibitors is better than some of the earlier work that was done where there was only 1 checkpoint inhibitor that was used. So again, so this is an immunotherapy designed to take the brakes off of the immune system and really allow the immune system to attack the tumor. So this is data from melanoma, so I just want to make that clear. But using 2 of these immunotherapies together was clearly better than using just 1 of them. And so that was really the rationale for doing this study, was can you use 2 drugs and actually kind of overcome resistance and just make it more effective for patients. And that was sort of rationale for doing this large study. Unfortunately, the endpoint was progression-free survival, and that was not found to be better than using just temozolomide. And so this combination, unfortunately, was not effective as it was like we saw in patients with melanoma. So the study was stopped early, but we're not exposing patients to toxic therapies that don't have a benefit. So I think this is really important work. So this is a slide that I've sort of developed just to kind of highlight some of the challenges. People always ask me, why doesn't immunotherapy work for brain tumors? And there's a large number of reasons, probably. It's probably not just 1 or 2, but these are a list of some of them. And one of them is, of course, these types of tumors occur in patients who are older, and older patients have their immune system is less effective. We as physicians and providers prescribe steroids, and steroids are also immunosuppressive. So those are a couple of things in clinically that have an impact. And then there's also sort of disease-related factors, and in particular, the the brain environment where the tumor lies is very immunosuppressive. So it kind of keeps the immune cells from being able to come into the tumor. And because of that, what we did, and I started working with one of my colleagues at MD Anderson, we thought of a drug combination study that we could use where we could actually maybe use a drug that might be able to overcome that immunosuppressive microenvironment by blocking these cells, immune cells called macrophages. So this is a phase 1 study. We're still in the phase 1 component of this. So a colleague of mine at MD Anderson, we started this before I left. Shapé Weathers ran the study, and it's a combination of using one of these immune checkpoint inhibitors together with another drug called cabozantinib, which is a very complicated name, but basically that drug is designed to keep these immune suppressive cells out of the brain so that the checkpoint inhibitor can enhance the immune cells and enhance their infiltration into the brain. So that's sort of the rationale for using the two drugs. And as a phase 1, as I mentioned, it's really small numbers of patients, really trying to find and identify whether or not the dose is effective or not, and whether or not it's safe. And so this drug now has this drug combination has been tested in I think about 6 patients. And of the first 6 patients, there were no major toxicities, which of course is great. And then there was also some evidence that there actually was some benefit in terms of response rates for the patient's tumors. And this just shows you an example from 2 different patients. And you can see on the left-hand side, a larger enhancing lesion that then gets smaller. And then the same is true for the patient on the bottom side. So very interesting. Again, this is phase 1. It's very, very early to make broad conclusions about this, but this is like the type of work that's very exciting and is kind of propelling the field forward. So I want to switch away from glioblastoma and talk a little bit about IDH mutant low-grade glioma. So as this is a very different disease, right? This is a very slow-growing tumor. It tends to occur in younger patients, sometimes in their 20s and 30s. And because of that, the goal is really to slow the progression of the tumor, obviously help patients live longer, but also to reduce the toxicity and symptoms, both associated with tumor progression, but also associated with more aggressive treatments such as radiation. So that has led people to think about trying to identify targeted therapies, and in this case, targeting metabolism of the tumor cell to keep them from growing. So I'm going to take a step back really quickly and talk a little bit about some basic biology concepts. I'm going to keep it really simple, and hopefully I don't confuse anybody, including myself. So as we all know, the genes in our cells are sort of the blueprint. And this is, I think, a really nice analogy. DNA serves as the blueprint for the building of our body. The RNA, so DNA, encodes the work orders. So what work needs to get done, that is what the RNA does. And then the RNA then encodes for the proteins. And proteins are sort of the hands that are being used to actually do the work, to build the building, to create the cells, to create the function that's going to happen within the cells. And then everything sort of looks orderly. The house comes together beautifully when everything is working perfectly. Proteins, this is just a really important point, is that proteins can be modified and they can be regulated. So in the next session, I'll show you that you can have changes to the protein which impact what happens sort of downstream from that with the building and everything else. So in cancer, there are certain changes that happen in the DNA that makes everything not work well. So one of them could be a mutation, and I'm going to talk about IDH mutations. So this is one of the reasons why I'm bringing all this up, hopefully not confusing everybody. But the mutation can cause downstream changes. Also, duplications of genes can cause problems, and we're not going to talk about duplications. We're just going to talk about mutations. But what you can see is that actually changes sort of what happens in the work order. And in this case, the genetic changes are causing the proteins to signal as always on. So everything is constantly on, and that then leads to cell growth that we're not wanting, right? And of course, then the house is completely the bricks are not being laid properly. So that's kind of the broader context of the DNA and how it affects the cell growth. And the reason I bring that up is that there are also targeted therapies that can, in this particular case, go from, a situation where there is a mutation in the DNA that then leads to the protein being altered, and then you can actually block that. So how does this relate at all to low-grade glioma and IDH mutation? So IDH mutations are sporadic. We don't know what causes them. It happens in a normal cell in the brain, but when that happens, it causes elevations in this metabolite called 2-HG. So IDH mutation causes too much 2-HG. 2-HG causes too much cell growth. So that's kind of like the genetic mutation that then leads to the change in the work order that then leads to uncontrolled cell growth. And this is really exciting, is that about 10 years ago, this was 14 years ago, this whole process was sort of discovered. And within 10 years, we have a drug which will probably get FDA approval next year for the treatment of this disease. So they have developed IDH inhibitors, which block the formation of this 2-HG and can stop cell growth and all the other bad things associated with it. So this study, this was actually presented at ASCO, which was maybe 5 months ago. There were several updates at the SNO meeting, which is kind of why I wanted to bring this up. But this was looking at patients with untreated grade astrocytoma or oligodendroglioma that had the IDH mutation. And patients were randomized 1-to-1. So this is a prospective, randomized, blinded phase 3 trial. So this is the definitive experiment that you would use to actually prove a therapy is effective, so that you can get FDA approval. So they blinded it, and it was randomized. Half patients got this drug called vorasidenib or vorasidenib, however you want to pronounce it, and the other half got placebo. And they were treated until something happened. Either there's a side effect or there was tumor growth. And the primary endpoint was what's called progression-free survival. So being alive without progression. And there was a very clear benefit in patients who were treated with the drug compared to those who were on placebo, where those who were on the drug had much less progression than those who didn't get the drug. And it seemed to affect and benefit a lot of people, just as a way of looking. They call this a forest plot. And the way of thinking about this is that when a bar is on the left-hand side, it's suggesting that the drug, this vorasidenib drug, was more beneficial. If it's on the right-hand side, then that would say that placebo was more effective. And you can, the big context here is that all of the lines are on the left-hand side, meaning that this drug benefited basically all patients, regardless of age, sex, where they were located, the location of the tumor, even the size of the tumor. So very, very exciting. And it was found to be true for both oligodendroglioma, grade 2, but also astrocytoma, grade 2, with the IDH mutation. So very exciting work. And hopefully this drug will get approval so that we can do more studies with it. So the last study I wanted to talk about was about meningiomas. So meningiomas are the tumors that are kind of outside the brain, come from the lining of the meninges that surrounds the brain, kind of protects the brain. And this has been a huge area of interest for multiple investigators at UCSF. And I wanted to just show William Chin's. He actually had the highest rated abstract of the entire meeting, and he is from UCSF. So we're really, really proud of this work, and his mentor, Dr. David Raleigh, the radiation oncologist. So I just want to, again, give you a little bit of background about meningiomas. When you look at the genetics of the meningiomas, you can see there are multiple different subtypes within them, and there's lots of details here that we won't go into. But the bottom line is that even though there's multiple subtypes, we kind of treat them all the same way. So, if surgery can be done, we'll do surgery, and then after surgery, patients get radiation. And we don't really have good markers to know, who needs radiation. Maybe a lot of patients don't need radiation. And then who are the ones who might benefit the most from radiation if we actually end up doing that. And so what this group did is they looked at a lot of different genes in the tumors, like we talked about, sort of the DNA blueprint for the tumor cell, and were able to identify a set of markers that showed whether or not patients would be less likely to recur or more likely to recur. And again, this is really important in terms of understanding who might need treatment early or who might not need treatment early. And then what they did is they took this gene expression profile, and then they looked back retrospectively, kind of as we talked about. So these patients have all been treated previously in the distant past across multiple continents, and to see who actually responded the best from radiation. They were able to demonstrate that the patients who were in the favorable group really didn't benefit from extra radiation, whereas those patients who were in the high risk or less favorable group really benefited from radiation. So very exciting work, and that is now going to be that gene signature is going to go into a prospective randomized clinical trial for patients with meningioma. So this is how this early retrospective work really can help inform how we do things in the future. So just in conclusion, SNO is an amazing meeting. People from all over the world are just incredibly engaged and working hard to develop new treatments for patients with all different types of brain tumors. Although none of the things that we talked about today were definitively proven, well, except for the vorasidenib, that's pretty definitive. But many of the other ones are showing some success, but at this point they're not changing the standard of care. But the next step, they actually might. There's lots of efforts to use combinations of drugs, to use combinations of immunotherapy, to use combinations of drugs and other technologies. There's ultrasound, there's laser ablation, there's lots of other things to really enhance the effectiveness of immunotherapy, and that's very exciting work. And then, as I mentioned, the groundbreaking work with the IDH inhibitor really opens up a huge opportunity for targeting metabolism and using targeted therapies for patients with primary brain tumors. So with that, I would just like to say thank you again for inviting me. I'm happy to take questions now or later, or however the team wants to do it.